our there you go. There is approved, and Yana, our administrator, on request will send you CPD certificates. So now it's my great pleasure to present to you Professor Dame Lesley Fallowfield, who is a cancer psychologist and a professor of psycho-oncology at the University of Sussex. She has wide research interests and is a very active researcher, having published over 400 papers, as well as many book chapters and textbooks. And in 2016, she was made a Dame for her services to psycho-oncology. And today she's talking to us about communicating prognosis in advanced cancer. So over to you, Lesley.
Thank you very much, Bridget, and good evening, everybody. I'm pleased that so many of you have found this topic interesting enough to log in, despite having, I suspect, already spent quite a busy day. This is a tricky topic. I'm going to talk about some research, some ideas I've got, and hope that although we've got such a wide-ranging audience, there are some things that people will find that are different and new to take away. Although I suspect for many of the professional clinicians within the area of palliative care, many of the sorts of things that I talk about will not actually be that unusual or surprising. I'd like to start with this quote from Tolstoy's Death of Ivan Ilyich. What tormented Ivan Ilyich most was the pretense, the lie, which for some reason they all kept up, that he was merely ill and not dying, and that he only need stay quiet and carry out the doctor's orders, and then some great change for the better would result. Now, that was written 135 odd years ago, yet I suspect there are still places where this sort of thing does still happen. So in this talk, I'm going to discuss some of the difficulties and barriers to actually being open about the prognosis with patients. I will sort of touch at the end of the talk on some of the added difficulties created by the current COVID-19 sort of pandemic. I'll mention the impact that learning diagnoses that are difficult and poor prognosis have on patient decision-making, touch a little bit on misinformation from the media and internet, and importantly, focus on the impact that being somebody who has to share difficult news with patients and their families has on them themselves, because I think if we only focus on the problems that patients and families experience, we're never going to actually change things, and we'll still have the type of problem that Tolstoy talked about in that earlier slide. So let me start by thinking first of all about the complexity of cancer. Over the last decade, we've had an explosion in understanding about genetics, the underlying molecular biology of cancer, and this has led to many, many therapeutic advances, which of course is wonderful. We've got better diagnostics, improved surgical and radiotherapy techniques, more systemic therapies that are better targeted at patients who might have a chance to respond to them. And all of these things together mean that many more patients are genuinely surviving well for longer. But all of this undoubtedly, all these changes and the research that have led to all these advances means that the whole area is no longer simple to explain. And the logic and rationale behind the different treatment options sometimes gets lost. We have to also think about the backdrop of any conversation with a patient, because one who is newly diagnosed with advanced disease or someone who's actually got a progression of their disease is already experiencing emotional turmoil. And they then enter this very strange new world with all this esoteric language and concepts that they have to get to grips with. Now, there are lots of difficulties communicating about treatment choices, and uncertainty is always going to make any communication much more difficult. All these problems are further compounded when patients obviously are desperate to hear positive and definitive information so that they can make choices. Patients also might well already have some very clear preferences, but they need very good information on which to base any decisions. And they can't make a wise and educated choice about anything if they're ignorant, not only about the therapeutic aim of treatment, but also about their prognosis with or without different treatments. Now, we know from lots of work that's been done that many healthcare professionals censor the information that patients are given. Doctors often try and protect their patients from difficult news, especially prognosis. Now, this isn't because doctors are horrible people. It's almost always really well intentioned, but stems from a misguided notion that what patients don't know aren't going to harm them. So it's probably better to leave them a little bit in the dark about the reality of the situation that they're in. There's also amongst many people still an expectations that if patients really want to know more, they'll ask. That if we're too explicit about what might happen, they'll experience unnecessary emotional distress. And if they do know the reality of their situation and prognosis, they'll lose hope and not enjoy the time left. And then finally, we often hear doctors say that the outcomes are far too difficult to predict with any accuracy. So that's one of the reasons that they never discuss prognosis. And I'm going to unpick some of these old excuses that are given for censoring information. First of all, patients do tend to want to know a great deal more than doctors realize. This is a really quite elderly study done by myself and my colleague Val Jenkins a long time ago now, but subsequent work has shown similar findings. This was just over 2,000 patients of varying stages of disease, different tumor sites, different ages, different socioeconomic groupings, who were going in for a consultation with doctors, oncologists and hematologists. And we gave them an information preference questionnaire to fill in. And then we were able, because we were recording the interviews, to see whether or not their preferences had actually been met. So there were lots of different things on this, but I've just put a few up here. And you can see that the large majority of patients, again, irrespective of the fact that this was a really heterogeneous group, wanted to know a great deal of information, including things such as the chances of cure, possible treatments. And very few said they would prefer to just leave it up to the doctor. They really didn't want to know very much about it at all. So to protect this very small minority, we leave the majority in the dark. Now, what's going on here? I mean, one of the things that we also looked at was doctors' satisfaction following different types of consultations that they had with almost 3,000 patients. There were 160 hematologists and oncologists in this study. Just over 1,000 of the consultations were about palliation because you'd come to the end of active anti-cancer treatment, and it was time to move on to supportive types of options. And just over 1,700 consultations were about active curative treatment, or the fact that the patient had entered remission. And the doctors were asked to rate their satisfaction immediately that the patients left the room. And fascinatingly, the mean scores were significantly lower whenever the doctors were talking about palliation. And what was interesting, because we had videotaped all the interactions that had taken place, was that some of these discussions had been handled beautifully. The doctors had been empathic and supportive and done them very well. But they actually really didn't feel happy whenever they were discussing palliation rather than active curative therapy. And we'll come back to that later. We then decided to look a little more closely at this issue of handling transitions from curative to palliative treatment. And the doctors rated their self-confidence on 10-centimeter visual analog scales with about how confident they were telling patients about side effects of treatment, that they had a recurrence, or that they were replacing active therapy with symptomatic care only. And you can see here, again, we have not only that doctors aren't satisfied whenever they talk about palliation, but when they have to discuss a transition, they're not even very confident about doing that. Okay, so let's look now at that issue about, are patients going to get too upset if you actually disclose the prognosis to them? This is an interesting study that was published in the JCO a few years ago, looking at almost 600 patients after they'd had at least one line of palliative chemotherapy. And the patients were followed up until death, which was median survival was about just over 5 months. Now, 71% wanted to know the prognosis, but only just over 17% of them recalled any disclosure of prognosis by their clinician. Those who recalled the discussion had much more realistic estimates of what their actual survival then ended up being. Those who had no recall of anybody having discussed prognosis with them, had also had no DNR discussions, were more focused on life-prolonging treatment than any comfort type care. And prognostic disclosure was not associated with worse physician-patient relationships or excess sadness or anxiety. In fact, the more anxious were those who actually had not, or felt that they had not heard, a discussion about prognosis. So let's look now at another thing that I think is really important. We've already got evidence that lots of patients don't recall having prognosis discussed, but as all cancer treatment now is a serious team business, it's very important that any doctor that does have a discussion documents it appropriately for their colleagues so that everyone knows what everybody's been saying. In this study published last year, they looked at the frequency, the form, and the documentation of prognosis discussions of just over 200 medical oncologists. It was done in Australia and New Zealand. 71% of the doctors involved in the study had had previous communication skills training about prognosis disclosure, and they felt that they conducted approximately 10 such discussions per month. 88% explained, they said, to patients that the cancer is incurable to all of their patients. 84% also said that they always or usually gave a quantitative estimate of survival. The preferred method of doing this was by using probabilities, and they said that they tended to talk to patients about the best, the typical, and the worst case scenarios. The barriers to being able to do this, though, were often family requests, or again, not knowing what the estimated survival time for the patient would be. Again, so we're coming back to this sort of hoary old argument. Well, I tend not to talk to patients about prognosis because I'm never quite sure that you can be that accurate. But you don't have to be accurate if you're an experienced doctor to give the best case, the typical case, and the worst case scenarios. Interestingly enough as well, only a fifth always documented these discussions and expected survival time in medical records, and only 11% in letters to other healthcare professionals. So patients were likely to get mixed messages. So what's going on here? We do seem to have a denial of death in most modern Western cultures. We deny death, celebrating instead all these wonderful new medical advances. And again, this is sometimes to preserve patients' hope for, good outcomes. And I think one of the problems that we've seen in many of the studies that we've done of the last few years is that not only patients, but also healthcare professionals often harbour quite unrealistic expectations about the likely therapeutic benefits of our modern medicine. Yes, we have improved, but not everybody with cancer is going to have a happy outcome. So if hope is centered solely around cure, then obviously truthful disclosure, particularly about prognosis, will destroy this. But I'd like to suggest, and I certainly have these discussions with colleagues, is that the preservation of unrealistic hope prevents a patient's energies being focused on the attainment of genuinely realistic and achievable goals. And I also think that it's completely unethical to encourage physically weak, exhausted patients to keep fighting for an implausible outcome. So let's go back to this often cited reason for not talking about prognosis, that it's too difficult to predict. Well, if it genuinely was too difficult to predict, then you would expect to see a Gaussian distribution of predictions, that some patients would live definitely longer than others, some the same as others, probably less, definitely less than others. What you tend to see, though, is that the failure to prognosticate is not just unpredictability, as prediction accuracy is really quite poor, and it's 90% in the direction of an optimistic error. So you don't see a Gaussian distribution, you see a really skewed distribution towards overestimation of how long a patient is likely to survive. And a disturbing finding that I'll talk more about later on is that the better the doctor knows a patient in terms of the length of time he or she has known that patient and the intensity of the contact that they've had, the more likely they are to overestimate survival. And this results in what I've described as doing something behaviours. Instead of having the honest but very painful conversation that's needed about prognosis and likely survival with different treatment options, doctors tend to get knee-jerked into doing something, ordering up another scan, ordering up yet another line of therapy. Now, the diagnosis of metastatic disease is obviously unpleasant. Fear of recurrence, even amongst patients who have been having honest discussions with their doctor at the early stage of disease. Fear of recurrence is common. but the confirmation that they've got a progression, that there's now spread, that they've got metastatic disease, still comes as quite a shock. There's still too many myths around about I've got the 5-year all clear from my doctor. I've never actually heard a doctor, after a patient has survived 5 years with their cancer, say to them, you're now all clear. Yet that's the message that many patients walk away with. It is difficult to be both honest but reassuring at the same time. And it's hard for a patient who's not one of the lucky ones to maintain trust in their doctor if that doctor has at the outset been overly optimistic. So let's look a little bit more at this. What do patients think when people give optimistic or less optimistic messages? This was quite an interesting study. 100 patients with locally advanced recurrent or metastatic cancer watched 2 different taped doctor-patient vignettes. They had to compare the perceptions of compassion and trust between the 2 vignettes. The doctors in these videos made equal numbers of empathic statements. Their body language was the same, but the messages they were giving over were either optimistic or less optimistic. The scenario was an advanced cancer patient who'd received several lines of chemotherapy, had a poor performance status, and was therefore not a good candidate for further anti-cancer treatment. Video A was explicit about this lack of further curative options. Video B, however, the doctor added vague information about the possibility of further anti-cancer treatments if performance status improved. So the results, well, more than half of the patients actually preferred the doctor who was delivering the more optimistic message, even though, as I said, their body language, empathic statements, the number of those were the same. A fifth had no preference, and another fifth preferred the less optimistic scenario. Higher perceptions of compassion were associated with a greater trust in the doctor, independent of the message type, whether it was optimistic or less optimistic. So what we're seeing is that patients are not going to actually see you as less compassionate. They're going to actually see you, if your body language and everything else is very good, as a trustworthy purveyor of the information. So it's not true that just because you're not being optimistic, you're actually going to get patients who are not going to trust you and are not going to see you as compassionate. Now, clinicians and patients may well have different values. If we're trying to sort of encourage our doctors to talk honestly with patients about likely outcomes from different types of treatment policies to pursue, we have to remember that people are likely to see things differently. Many of our cancer treatments offer improved progression-free survival and some overall survival. But many have also got the problem of some really unpleasant toxicities associated with them and some others serious side effects. The true benefits of many of these exciting novel drugs are often modest or sometimes uncertain due to limited follow-up. And so the desirable benefits and acceptable costs might differ between patients and healthcare professionals. It's very easy, if you are a clinical scientist, to become quite excited about the latest data from ASCO or ESMO or whatever else. But without lots of information about quality of life and more information about what a patient perceives as important, some of these modest improvements might be of no relevance to a patient. Now, A patient, obviously, if they're going to make a decision about a novel drug, does need to know the likely therapeutic outcome and prognosis. And we hear a lot now about shared decision making. But with shared decision making, the relationship is never going to be symmetrical. Clinicians have got lots of power through their extra knowledge. And of course, they don't have to experience the treatment consequences. Patients have to know before they make a decision about the therapeutic intent. Is it to cure, to palliate, or just control the cancer? What's going to be involved with different sorts of treatment options? How many visits are going to be required? What's the mode of delivery? Is it going to be IV or is it oral? What are the risks, harms, and possible benefits? Then, is the lengthier survival worth these treatment side effects? Indeed, how much survival benefit is going to be necessary to trade off the disadvantages to lifestyle and constantly having to go to the hospital for treatment with side effects? And if there's no clear survival benefit, between different policies that a patient might pursue, then quality of life information is absolutely crucial and influences patient preferences. So are novel drugs worthwhile? Well, as I've already alluded to this, clinical trials of drugs with only PFS or modest OS benefits often show few quality of life data. Research suggesting that patients will accept very high toxicity for only minimal benefits in survival are often extremely flawed, and I could do another talk for an hour on that subject. There are hypothetical studies also that suggest that PFS is worth treatment-related side effects. So we decided to study this premise contemporaneously in a study called Avoprost, Accessing the Value to Patients of Progression-Free Survival. We measured the quality of life in patients who are about to start drugs that only had PFS benefits, and we established how worthwhile patients felt control of cancer was versus the side effects experienced, the time that patients would require the treatment to continue controlling the cancer as side effect severity increased. And we also asked doctors what benefits they expected to see. So following consultations, the oncologists completed checklists that were probing information that they had provided, and they indicated how much they thought the patient had understood. They estimated the percentage of patients in general who might achieve some clinical benefit, what benefits they expected for the patient they had just seen, the life expectancy of these individuals with and without further anti-cancer treatment. And the patients were interviewed in their own homes within 2 weeks of that consultation. Then again, if the drug was stopped for toxicity or due to progression. They also completed cancer and treatment-specific quality of life questionnaires monthly and did time trade-off interviews with us as to how worthwhile the treatment was or would be with the different side effects against the time the treatment might continue to control the cancer. So here is the first paper with great difficulty that we published, called The Therapeutic Aims of Drugs Offering Only Progression-Free Survival Are Misunderstood by Patients, and Oncologists May Be Overly Optimistic About the Likely Benefits. We had great difficulty publishing this study, as we even saw one reviewer of a quite important oncology journal say, "I don't believe that doctors are overly optimistic or would fail to ensure that treatment was only given to patients likely to benefit." Well, let's have a look at some of the data. We had 32 oncologists, fabulous doctors, treating 90 patients with metastatic lung, breast, ovarian, colon, renal, head and neck cancers and multiple myeloma. We had 139 patients participating, but 50% died or became too ill to continue through to 6 months follow-up. The results from the oncologists, as far as the percentage of patients they expected in general to derive any medical benefit from the given drug for a specific cancer, was extremely variable. 10% to 80%, which bore no relationship to what the clinical trials had actually shown. Doctors thought that more than half of their patients would derive some medical benefit, but prescribed treatment for the other 49%, even if benefit was unlikely. Remember when I said that doing something behavior rather than having an honest conversation? The estimations of life expectancy varied wildly. 62% of patients were predicted longer survival, even with drugs that had only ever shown a progression-free survival benefit and was way beyond what any of the clinical trials had shown. And remember, in real life clinics, you're not getting patients who would have ever even been eligible for a trial. You're getting patients with comorbidities and all sorts of other things. And alarmingly, only half of the consultations included other supportive care plans rather than this novel anti-cancer systemic therapy. What about patients' understanding of what was happening? Obviously, communication when discussing treatment impacted their expectations and adjustment, but the majority had no idea what was really going on. 50% of them thought extension of life was the primary therapeutic aim. Their comments included, I think it would mean I would get a few more years, no idea, being free of it, sounds positive, hopeful to me, as it's got the word survival in it. By 4 weeks, 96% experienced side effects that were impacting on their activities. And as severity of the side effects increased, patients were significantly less inclined to feel that the benefit of controlling the cancer was worthwhile and would require much larger increases in the time it did so for the treatment to be worthwhile. So they wanted more benefit from it in cancer control than any trial had ever shown the drug to achieve. So discussions with patients about metastatic disease and the benefits of further active therapies are undoubtedly challenging, but it is really important that our oncologists retain a perspective as to what constitutes meaningful benefit and provide realistic prognoses for their patients with and without treatment. Improvements in symptoms of disease and obviously a good quality of life is important, not just the arrest of tumor burden when you look at imaging or reductions in tumor markers. And I think that patients have got to have more honest information about what is going on and focus on ways to help patients understand these complexities. This is not easy stuff to talk about. Now, if information is insufficient, patients and their families are obviously easy prey for the charlatans that inhabit Dr. Google. And the media also often raises expectations. We hear all these, the triumphs of the latest new sort of drug that's going to cure cancer, when in fact it's not going to actually deliver quite the sorts of benefits that patients would like. I just typed in what is the best treatment for non-small cell lung cancer, and one of the first hits that came up was stage 4 cancer survivor. Here's how I survived. I went from terminal to survivor in 3 weeks thanks to a Mexican clinic. And the son had, back from the brink. Non-smoker claims terminal lung cancer shrank by 75% after seeking alternative treatment in Mexico. So it is difficult when we're also competing with the misinformation that's being given. And if patients don't feel supported, they're likely to actually believe in some of these charlatans. Now, when there is no further systemic treatment available, some patients also refuse to accept that. They've run out of these types of options. They might, of course, be offered phase 1 trials. And it's arguably even more important to ensure that they understand prognosis in this setting. Sorry, I heard somebody say something then. Okay, I just want to sort of show you some data that, again, my sort of team did some time ago. We were looking at the conversations that took part when somebody was being recruited to a phase 1 trial. And the paper was called "What Oncologists Believe They Said and What Patients Believe They Heard." Now, this is a complex slide to look at, but essentially what we had were consultations being recorded between doctors and patients, which we were then able to listen to and code in different ways. So this was about prognosis, and essentially wherever you see a big black box or a little black box, this shows you how much agreement there was between the clinician and the patient, the clinician and the person coding the interview tape, or the patient and the coder. And the only place basically where you see a big black box is agreement between the patient and the person doing the coding that there had been no discussion about prognosis. Clinicians reported discussing it in 50% of cases, but only 6% of the patients said it had been discussed. We only heard it in 20% of cases. And as I said, there was only significant agreement between the patient and the coder that no one had mentioned prognosis. So if we're going to optimize communication with our advanced cancer patients and not let them lose hope, we obviously have to start with a platform of certainty about the issues that are clear, reinforce the message that many patients with metastatic disease do live well with a good quality of life, give patients a realistic understanding of the likely prognosis with and without different treatments, and give grounded hope in credible, reality-based possibilities without being nihilistic also about good quality supportive care options. We know that there are many data showing that early referral benefits not only psychological, but also physical well-being and survival of the patient, and it's valuable for caregivers as well. But doctors admit to difficulty initiating such discussions, especially if they've got a close emotional bond with the family and the patient. And some feel it's an admission of defeat or personal failure, and others are responding again to these unrealistic hopes of patients and families for implausible outcomes from further anti-cancer treatment. A few years ago, ASCO started a Choosing Wisely campaign, trying to stop aggressive care at the end of life, particularly for younger patients with cancer. They looked at nearly 30,000 patients under the age of 65 who died from a variety of different metastatic cancers. 3/4 were still receiving aggressive anti-cancer treatment within the last 30 days of life. Almost 1/3 of them died in hospital, and rates of receipt of aggressive treatment was unchanged since the Before Choosing Wisely campaign. for colorectal and breast cancer patients, and in all the other cancers had actually increased. Hospice use in only about 14 to 18% of patients suggests that there was a substantial overuse of aggressive treatment at the end of life. And of course, it begs the question as to whether or not patients knew their prognosis and the therapeutic aims of treatment. Communication failures about prognosis result in the patient becoming twice removed from it. Foreseeing, which is the unexpressed cognitive estimate about survival, is likely, as I've shown you, to be overly optimistic. And foretelling, that's the communication of it, is subject to all sorts of conscious and unconscious ambiguities or even deliberate evasion. Now, it is difficult for healthcare professionals, and I want to just sort of end the last 5 minutes on talking a bit about professional boundaries. There are many evidence-based courses to help doctors communicate in clear, honest, and empathic ways, but far fewer on how to navigate boundaries between personal and professional involvement, or on how to handle the emotions provoked when you're dealing with somebody who so wants to live, yet you know that further systemic anti-cancer treatments won't help. They experience lots of feelings. I mean, the patients are sad, yes, but doctors feel sorrow, guilt. They might over-identify with the patient or feel a failure because they haven't been able to save everyone. And there's little evidence from the work that we've done with even quite senior doctors that these sorts of feelings get easier or better over time without support. Now, I'm one who's encouraged doctors to become more empathic, to get closer to the emotional needs of their patients and families, but it does put the doctors at psychological risk themselves. We did a study that was published in the Lancet Oncology a few years ago, looking at this issue about whether or not, if you are close to a patient or like them, you're not actually likely to be as truthful about prognosis. This was a survey done with 338 young oncologists who were members of ESMO. And as you can see here, over half of the women and almost 2/3 of the men said, yeah, if I really like a patient, I find it really hard to be truthful about prognosis. It's got the horrible sort of, conclusion here that if you really want honesty about your prognosis, go and see a doctor who doesn't like you very much, I guess. Now, I want to end with communication during the current pandemic. I've published a paper recently in Trends called Enhancing Our Website Manner, which gives much more about remote consultations. That, incidentally, is my daughter trying to communicate with her young, chronically sick patients in All the Kit. PPE can be intimidating with the loss of facial expression, the muffling, the limiting of informal carers during face-to-face consultations and visitors may also increase fear. This situation is really alienating for our sick patients who need support. And remote consultations are fraught with difficulties and potentially even trickier if the news is not good. The 18-week standard of patients being seen prior to the pandemic was always pretty ambitious and maybe even unrealistic. And the diversion that we've seen of staff and resources will inevitably have consequences. It's quite likely that the outlook for some patients might now be bleaker due to delays in referral, diagnosis, surgery, and of course, sometimes the suspension of treatment. I guess arguably the absolute benefits of some of the chemotherapies used in palliation are marginal, so might well be postponed anyway, leading to some quite difficult conversations with patients. Recent interviews in the UK of patients recruited by Healthwatch have shown mixed views and experiences with remote consultation. Most were pleased to just have a call, and some just pleased to be seen. The majority thought video was better than just a telephone call, although there were lots of frustrations with the IT. Other studies have suggested that patients like the convenience of remote consultations, but certainly don't want bad news delivered in that way. So, just to end now, I think we've got to learn to be better truth tellers, work as a team to ensure that the same message is given and received, help patients and relatives define achievable goals rather than embark on anti-cancer treatments with implausible outcomes, but recognize that we too have neediness and motives perhaps for not always being quite as direct as we need to be. We have to beware of this folie à deux of believing in miracles and be less nihilistic about supportive care. And I want to end with this quote by Nicholas Christakis from Death Foretold. Rare are the cases where making or offering a carefully considered and framed prognosis results in choices that are harmful to the patient. As a result of a failure to prognosticate, let alone prognosticate accurately, patients may die deaths they deplore in locations they despise. They may seek noxious chemotherapy rather than good palliative care, enroll in trials of experimental treatment that offer more benefit to the researchers than to themselves, or reassure loved ones that it's not yet time to pay a visit, only to lapse into a coma before there's time to say goodbye. I'd like to thank all of my wonderful team at Shawsea who've contributed in all sorts of different ways to some of the data in this talk and my understanding of it. Here we are in happier days, and here we are now. Let's hope we can revert back to the previous slide sometime soon. Thank you very much.
Thank you, Lesley. I think that Paddy is going to draw the talk to a close, and then we're going to open up for questions. I think that's the way I was told the schedule was today.
Yeah, just very briefly, really, because Bridget's chairing the meeting and is going to marshal the questions. But we thought we'd just give people a little bit of time to write some more questions in the chat. While I thank you, Lesley, thank you so much for the talk. And we're so lucky to have had somebody who's undertaken all of the research over decades. I hesitate to say, but over decades. And you know, we're really privileged to have had you take us through all of that. And thank you very much indeed. I'm just, while we're waiting for people to write some more questions up for Bridget, on the topic of prognostication, we have a PhD student in our department at the moment who's doing a project looking at how doctors and nurses between themselves make decisions about prognoses. And we were hoping that people who are watching the talk tonight might take 15 minutes at some stage over the next few weeks to participate in an online study where we're interested in seeing how doctors and nurses respond to advice about prognostic decisions. So I don't know if I've succeeded in putting my screen up, have I? Can anybody tell me that?
It's come up on my screen anyway.
Perfect. So you're seeing the information about it. Great. So we'll just leave that up so people can copy down the website address and could go and take part in that study if possible. Right. Well, thank you very much. The other person I want to thank actually is Bridget, because Bridget's been organising these seminar series now for 2 years and is going to be stepping down and handing over to Nicola White, who will be taking over running the seminar series. And so I just wanted to thank Bridget very much for organising this. Every seminar series lecture seems to get more and more of an audience, and Lesley's broken all of our records with tonight's audience. So thank you very much to both of you. And I'll hand you back to Bridget to marshal the questions.
Thank you, Patty. I have a little problem with chat. I don't know whether Nicola, my colleague, can you see the chat questions? I've just got.
Yeah, the chat window's popped up for me.
Okay.
So that I can go through them. That's okay. It might take some time.
Oh, hang on, I've got it. I've got the right.
But there is, so the first one that popped up was from somebody called S. Chadwick, who was wondering whether or not there were any differences that you noticed between oncology specialties in terms of prognostic communication.
Huh, that's really quite an interesting question. I haven't actually studied it explicitly, but obviously there are certain tumour sites where the prognosis is almost certainly going to be less happy for the majority of patients than others. So if you, let's say, are an oncologist who deals with breast cancer, you've got a pretty sort of wide distribution of people who you are genuinely likely to cure, others who are going to survive for a long time quite well with, metastatic disease, and others who will die. If you're somebody with some of the hematological cancers, some of the GIST cancers, maybe head and neck, the sort of outcomes there are often a little gloomier, and brain tumours in particular. I'm not convinced, though, from the work that my colleagues and I have done over the years, that people are necessarily, just because they're inured to the fact that many of their patients are likely to have gloomy outcomes, that they are always more honest about likely outcomes. Often, though, it is, I think, in response to family and patients almost sort of hoping against hope that things are going to be better. And when I showed you those slides about doctors sort of thinking that they're not actually as honest about prognosis as they could be if they like the patient, and that was something that Nicholas Christakis had shown in his early studies 20, 30 years ago, looking at prognostic accuracy. The more that you knew a patient, the more that you empathized with them, were in touch with them, the less honest you were likely to be with them. I haven't really answered the question there.
That was fabulous, thank you. There was Peter Buckle who sort of responded to that question as well. So he is a cancer widower, and he said he doesn't feel like, that he feels like there is a difference. His wife died from a glioblastoma, and it's always terminal, but they had the failures that you described in your presentation. Bridget, do you want me to carry on?
No, I've actually found it. So I got the next one, which is from Thea, who says, "Thank you so very much, it's very helpful. And I know I'm guilty of a lot of these issues, but can you comment on navigating through cultural and language issues? I work somewhere with 28 commonly spoken languages, harder still with interpreters also web-based."
Oh, this is such a difficult thing, and it's something we've really got to get to grips with. We live in a multicultural environment, and it's very hard. It's not just the language, though. There are some sort of some cultural expectations that I think make these sorts of discussions harder, because you're rarely talking to just the patient. You're often talking to a whole plethora of other relatives as well, some of whom expect to be the ones to make the decision and to have most of the information sort of given to them rather than the patient. Paddy's a PhD student, I think, if I'm right, might be someone who's working with Belinda Kiley in Sydney. They've been doing a lot of work on prognosis, and they have been doing some interesting work on looking at differences between people whose language perhaps isn't English. We can do a lot more work on this, I think. We have to get to grips with it.
Certainly lots of cultural differences, isn't there? With Chinese people there's a lot of death taboo, isn't there, and that kind of stuff, not wanting to talk about it.
Yes, that it actually almost sort of will enhance the likelihood that you will die if you talk about death. So that makes it all very difficult.
Do you want to do the next one?
Yeah, sure. So there's a question from Helen Brewerton, and she said, do you think it's better for doctors to be overly optimistic and actually answer the question about prognosis rather than dodge it completely and not answer?
Well, I don't see that the existence of that dichotomy. I think you should be honest. Neither dodge the question nor be overly optimistic. I think that the thing that I actually sort of alluded to with a lot of people who work in this area now feel that the most appropriate thing to do, because with your knowledge as an oncologist, you've seen the data, you know what sorts of outcomes are likely to be achievable with best case scenario. You also know what the likelihood is if you add in a few other factors with the patient in front of you, their performance status, their age, their general state of health, etc. So to give patients the, how most people do, what in fact would be the best thing you'd ever seen, and what is the worst outcome you've ever seen with the drug or treatment regimen that you're ordering up. I think we ought to get better at doing that for patients. And if the patient then says, well, where do you think I lie on that sort of spectrum of outcomes? Well, I think perhaps you should forewarn them. I mean, it's this old thing about sort of then helping a patient feel that it's worthwhile, if you genuinely feel the treatment is worthwhile, that they should hope for the best outcomes, but be prepared that it might not go quite as well. And I think the important thing also is that when people are discussing these things with patients, they must actually have good supportive and palliative care there up front. It's not that you're going to either give patients a new treatment that might work or not. It's that you're always going to look after, as far as possible, their symptoms. There's always something you can usually do about appetite, mostly something you can do about pain as well, for many of our patients. It's just terrible when I hear patients say that, or their relatives say, the doctor said there was nothing left for me to do, that we've just given up now. Nobody ever gives up on a patient. There's always something we can offer them, but they're only going to be accepting of those things as a valuable outcome, I think, if they've recognized that that is a possibility that they need to entertain and think about.
We're coming up to an hour, but I know that you're happy to stay on, aren't you?
Just for a while, if others sort of actually are finding this more interesting than a gin and tonic and their dinner.
Okay, so there's lots of thank yous here, but there's one about, I'm curious as to, Navia, I can't pronounce her name, says, I'm curious as to whether training is available to help clinicians reflect on what they bring, their positions in these conversations, and how that influences the way they approach the topic. And there's a second question, which I can read out as well, or remind you in a minute, is how to actually have conversations with service users in the way that is meaningful and useful, as in what specific techniques and skills and questions should you use?
Well, actually, I think I skipped over. I don't know whether I can go back to my screen. Can I go back to my screen? Probably not. Let's see if I can. Am I sharing the screen?
Yeah.
Yeah. One thing to consider is that some people have done, and here is the reference to one, is to give patients and their families prognostic focused question prompt lists. And I think this is quite a novel and interesting thing to do. This is obviously American, but we could easily sort of anglicize this a bit more. To actually give these things to patients and their families before they come and see the doctor, so that they themselves can consider what they actually do need to know. As I said, doctors often say, well, patients will ask if they want to know more things. Often patients don't know how to articulate the right sorts of questions. And if we could actually encourage perhaps doctors to give out these to patients or a version of them, that might help the conversation along. Or it could be that the doctor themselves uses this as a sort of script. Now, would you like to know what to expect in the future? What the best and worst case scenario would be with different treatments? What I would see as a good outcome might not be what you would see as a good outcome. So I think using these prompt lists is one sort of thing that people might feel is sensible to do. I want to go back though to that thing that somebody asked about, are there courses? Well, there's loads and loads of courses you can go on. I hate these things on Breaking Bad News. It's not Breaking Bad News. It's discussing sad, bad and difficult things with patients. And the best ones always involve some part of the course on how to deal with the feelings that doing these things provoke. We have always, on the courses that my team run, looked at not just providing people with, if you like, a cognitive basis for how you should structure an interview, what the latest data show if you do one thing rather than another. We don't just focus on that, we also focus on the more experiential side of it. And one of the things I'm always interested in is if doctors that I know are very good and are usually sort of quite articulate, if they actually omit certain things in interviews persistently, it is because it's just hurting them too much to continue doing it. Unless you address that, we're never going to actually improve things either for patients or for the doctors themselves.
Okay. What's your next one, Nicola?
Yep, so there's a question from somebody called VG, who says, there's a feeling sometimes that we're forcing information onto patients, including prognosis. Should we ask them if they want to know the prognosis first? And what do we do if they don't want to know?
Okay, well, remember that slide that I showed at the beginning, that we did of nearly 3,000 patients of a variety of ages, stages of disease, different tumour sites. And the vast majority said that they did want to know all aspects of information, be it sort of good or bad. But when they were in the clinic, they were often a bit too scared to bring the subject up. So I think that if the doctor isn't brave enough to say it gently and kindly, you've got a problem, haven't you? Assuming that just because the patient never actually brought it up, they don't want to know. So I think it is important that doctors say to patients, depending on who's in front of them, things like, now we've got some difficult things to discuss, and I know that some patients, you know, prefer more information than others, but there are certain things that I feel it's my duty as a doctor to share with you if you're going to make a sensible decision that's going to be right for you about the further sorts of treatments we might offer you. Because I don't want to give you something that doesn't necessarily improve the outlook for you, just gives you lots of side effects, unless you're really sort of sure that that's actually a balance, a chance you'd like to take. So I think you can do it in all sorts of different ways, but I do like that way of saying to people, I think it's my duty to actually share with you the fact that not everybody does well with these sorts of scans, with these sorts of results in terms of further active treatment. And I'd like to sort of talk to you about what the likely outcome will be if we don't give you more of this treatment, what it will be if we do, what the best outcome, worst outcome, or most likely outcome are. But I really want you to go away from this meeting knowing that even if we decide not to carry on with further anti-cancer treatment, there are other treatments we're most definitely going to do. I had a lovely experience with a doctor many, many years ago, and I often quote her. She actually always used to say to patients when you got to that awful transition moment where it's quite clear that further, you know, anti-cancer treatment was not sensible, that the disease was progressing, all their sort of, you know, sort of measures were looking awful. And she would say to them things, you know, I think we've got the best we're ever going to get from the chemotherapy now. And it's time to talk about many more things that we're going to offer you. So she'd go straight in with the pain control, the symptomatic relief stuff. And then it was sort of a bit easier for the patient not to just suddenly think, oh God, they're stopping treatment. You know, they're not going to do anything more. The problem that people don't seem to sort of quite latch on to is that discussing prognosis doesn't mean the end of the discussion. It opens up an opportunity to talk more about the things you genuinely can offer people in terms of good supportive and palliative care.
Shall we just do another couple of questions? This is sort of going a bit backtracking to your previous question, which was somebody wants to share that they recently read about Spike's model for breaking the bad news, and they just wondered if that can be used during prognosis discussion.
Spike's was developed by a guy called Rob Buckman, who sadly is dead now. He used to be at UCL actually, and I worked with him and ran lots and lots of communication skills, courses and programs. He was a very charismatic figure. Spikes is not something that I personally use though. I rather disapprove of cookbook type, you know, sort of approaches to communication, you know, establish eye contact, greet patient, you know, it's not like that in the real world. But I think Spikes does provide different categories of things that you might involve the team in doing, not necessarily just you, with patients when you're having difficult sort of consultations with them. I think Spikes is a bit American as well, and we are different from them. We don't speak quite the same sorts of language as them. I think that you can read lots and lots of helpful things on how to initiate the discussion, but fundamental is, I think, ensuring that you are at the right level that the patient is at, that you appreciate what knowledge base they have, what their expectations have been before you launch into the difficult discussion. So spikes, it's good for some people. It's not a system I personally use.
Thank you.
Is that time, do you think? Should we
do another one, or?
I'd say I think we've asked a lot of questions now. It's running on a bit.
There are a lot of questions. There's lots of thank yous and incredibly informative discussion. So I'm sorry if we haven't answered your question, but please send them in. And they'll probably be recorded, won't they, Nicola? No, I don't know if they do.
I think we get a sort of transcript, or I'm not quite sure.
No, I'm not quite sure, but if you have some burning questions, please send them in and we can send them on to Lesley. So what I'd like to do now is to thank you all for attending, and thank you so much for this talk, Lesley. It was very informative.
My pleasure, and I hope that you all stay well and virus-free and get vaccinated, and that we can all move on so that we can actually see each other in person again. Yeah. And Paddy's got to take me out to dinner as a thank you.
He owes you one, doesn't he?
Absolutely. Absolutely. Looking forward to it. But thank you very much. You've been very generous with your time, Lesley, by overrunning and answering all those questions. So thank you very much. And I'm sorry we've had to leave some people's questions unanswered tonight, but I think it's only fair that we let our speaker and perhaps our hosts go off and have a gin and tonic to celebrate. So thank you very much.
Yeah, I don't know if anyone wants to unmute and just try their appreciation.
Yeah.
Thank you very much. That was really, really interesting.
Thank you. Thank you.
Thank you. Thank you.
Bye-bye. Thank you very much, Lesley. Bye-bye now.
Bye-bye.
Thank you. Thank you very much.